April, it is pleasant, yes.
Acha, right, sir, right. I was the one who called you, sir. I'm in Bhilai, basically.
Ji, Naresh.
Proper.
Anybody has any questions, queries, you can feel free to write on the chat box, and Dr. Naresh sir or me, somebody will look at it and keep answering in between or later on. Okay.
I
Keep
request
it very
everyone.
informal. Yeah.
मैं रिक्वेस्ट करूंगा सब वीडियो ऑन करके रखें ज्यादातर हो सके तो. Please switch on your videos and be interactive whenever prompt for. Time हो गया sir. Shall we start, sir?
Yes,
People
please start.
अभी थोड़े join करेंगे, but we'll start. Okay.
Yeah.
So, good evening. On behalf of Durg Bhilai Academy of Pediatrics, I welcome you all to this PG clinics. So today we are very happy and we are pleased that Dr. Tushar Maniar sir from Mumbai has joined us for the first time. We welcome you, sir.
Thank you.
Sir is HOD Pediatrics, Nanavati, Max Super Specialty Hospital, and he also owns the website, very popular website for OSCE, that is oskipediatrics.com. Sir is also the director for Maniar Clinic in Andheri, Mumbai. He is a very important contributor for the Nelson's Essential book and also for the Elsevier Point of Care book. And we welcome you, sir.
Thank
and
you.
Dr. S. Balasubramanian, sir, is also our expert, but sir will be joining little later, as I was informed. And Dr. Salil is our first year DNB from GOPAL Children Hospital, Raipur. So as a it's 8:45 already, so I request Dr. Salil to please present your case. And I welcome all our pediatricians from Durg Bhilai, all the postgraduates, and all the pediatricians and academicians from across the state of Chhattisgarh. So, Dr. Salil, please go ahead.
Yes, sir. Good evening, sir. Myself, Dr. Salil Singh Kushwaha, first year DNB resident. I'll be presenting the case today. Starting with the chief complaint, Abdul is a 3-year, 10-month-old male child born to a non-consanguineous married couple, third in birth order, Muslim by religion, hailing from Bhilai, Chhattisgarh. Informant being mother, who is a reliable informant, brought with chief complaint of fever for 3 days, vomiting for 2 days, and pallor for 1 day. Coming to the history of presenting illness, child was apparently all right 3 days back when he developed fever, which was sudden in onset, low grade around 101 degree Fahrenheit, continuous in nature, getting around 4 spikes in a day, having no diurnal variation, relieved by oral medication, and during interfebrile period, child was active. Child also had 2 to 3 episodes per day of non-bilious, non-projectile vomiting, which was usually occurring after intake of food containing food particles. However, on 3rd day of illness, mother noticed paleness in the child, for which he was brought to GOPAL Children Hospital for further management. Coming to negative history, no history of seizure or altered sensorium, no history of pain in abdomen, loss of appetite or jaundice, no history of passing clay-colored stools or dark-colored urine, no history of burning micturition, no history of any bleeding manifestation or blood transfusion, no history of fatigue or pica, no history of rash. Past history, child had 1 episode of febrile seizure in December 2021. And coming to antenatal history, first trimester, no history of fever with rash, lymphadenopathy or drug ingestion in mother during first trimester. Second trimester, no history of pedal edema, headache or blurring of vision, no history of polyuria, polydipsia or itching in mother. Third trimester, no history of maternal fever, leaking PV, no history of UTI in mother. However, at the time of delivery, mother VDRL test came to be positive. Now coming to natal history, labor pain was spontaneous, delivered at term by vaginal delivery, not assisted. Birth weight was around 2.75 kg. Baby cried immediately after birth. Breastfeeding was started in first few hours of life and baby passed stool within 24 hours of life. Baby developed neonatal hyperbilirubinemia on day 3rd of life, having total serum bilirubin around 23.1 milligram per deciliter, for which he was admitted to an ICU and received exchange transfusion. However, mother and baby blood group were A positive, G6PD was not deficient, reticulocyte count was 2%, and direct Coombs test was negative. Baby also had neonatal seizure, for which Levipil was started and were given for around 6 months and then tapered and stopped. Baby was, just a second. Baby was born to VDRL positive parents. VDRL testing of baby came to be reactive, but baby had no systemic feature of congenital syphilis. So single dose of IM benzathine penicillin was given. Hearing screening was done, which was normal. Breastfeeding was started soon after birth, and child was exclusively breastfed till 6 months of age. Complementary feeding was started at 7 months of age with dal pani, khichdi, and cerelac. Breastfeeding was continued till 1.5 years of age. Coming to immunization history, child is immunized as per age. And then coming to dietary history, child is on mixed diet, having calories intake of around 1200 kilocalories with a gap of 100 kilocalories. Protein intake around 17 gram with a gap of 2 gram. Developmental history, child has attained age appropriate milestones. Now coming to family history, father is 38 years old and mother is 29 years old. Child is third in birth order, born to non-consanguineous married couple. Elder siblings are 7-year-old sister and 5-year-old sister. Both are thriving well. Father has a history of recurrent jaundice with splenomegaly and gallstones and had undergone cholecystectomy and with splenectomy at the age of 20 years. No history of blood transfusion in the parents, no history of sickling in the parents, or no history of seizure disorder in the family. Socioeconomic history. Father is educated up to 12th standard. He is a policeman by profession. Mother is graduate and is a homemaker. Lives in own pakka house. Sanitation is closed. Drinks RO water. Per capita income is around 5,000. Belongs to lower middle class family according to modified Kuppuswamy scale. Then coming to summary.
Don't give summary. We can go back.
Yes,
We'll
sir.
discuss the history. We'll ask some questions and then we'll come to summarizing it and then we'll ask you about the differential diagram. Okay.
Yes.
That's how we'll try and keep it.
Yes.
Let me see if I can make this. Yeah. Okay. This is better. I can see more participants, then we can ask more questions. Very good. So can I take names of people so that we answer? Salil, Dr. Salil has already done a very good job in giving very nice and detailed history. So I would want all of you to participate. So can you all unmute yourself if there is no background noise so we can quickly ask questions and then we can answer. Can we go to the next slide, Dr. Salil?
Yes, sir. Yes.
Yeah, so we'll start the other way. Whatever queries or discussion points are there, that we'll take it and then we'll go to the main question. So can you tell us more about something more about the febrile seizures?
So child had one episode of febrile seizure at around 1.5 years of age. He was admitted for a few days, took treatment and then was discharged. And
so
then,
when do you call it simple febrile or when you call it complex febrile? Naresh sir, I think we should, you want me to take it as a discussion case and not as an exam taking case, right?
Yes,
we'll
sir,
keep
yes,
it as a discussion only, right?
Yes, sir, yes,
Okay.
yes.
Okay, fine.
Sir, it is called simple febrile seizure when the seizure occurs within 24 hours of fever, and seizure usually lasts for less than 15 minutes. And no postictal drowsiness, I think.
Okay,
that's it.
So it's good idea to describe the febrile seizure and give us more details about how many seizures happened, one or more, what was the interval between them, how long did the seizure last, how did the seizure abort, whether it was spontaneous by the time the child was brought to the hospital or some medication or intervention was required?
No, sir. Child had only one episode of febrile seizure and it aborted before coming to the hospital.
Okay. Okay.
Yes, sir. And after that, he had no further episode till now.
Fair enough. Dr. Garima, can you unmute yourself? Are you there? Okay, Dr. Ruchika Garima.
Yes,
Okay,
sir.
right.
Yes, sir.
Yeah, Dr. Garima, can you tell me more about hyperbilirubinemia? What have you understood from that slide? Salil, can you go back to?
Yes, sir.
Can you show me the slide where you have mentioned about hyperbilirubinemia?
Yes, sir.
Okay, very nice. Garima,
Sir,
can you look at each line and tell me what is the importance with respect to hyperbilirubinemia in this patient?
yes, sir. Sir, this is a case of indirect hyperbilirubinemia, sir.
Very good.
And it can be because of any hemolytic.
Okay.
The cause can be hemolytic.
Okay.
But direct Coombs test is negative.
Very good.
That is against hemolytic anemia, hemolytic hyperbilirubinemia.
And there is no RH incompatibility as well, right?
Yes, sir.
And is there any blood group incompatibility?
No, sir. Blood group is also same. So there is no ABO incompatibility also.
Very good. So it's a good idea. Nicely you said it's no ABO incompatibility. Can there be non-ABO blood group incompatibility? Salil, Dr. Salil?
Yes, sir. Minor blood group compatibility can be.
Excellent. Excellent. So if it was RH incompatibility, what would have been the presentation? How would it be different than what it is currently? In a typical scenario, most commonly, I'm saying. Yeah, Dr. Subhash. Any thoughts, anybody? How does an RH incompatibility present? Dr. Vatsala? Okay, Dr. Salil, I think you have the onus to answer if no one answers.
It presents as acute hemolysis. Then
what is the onset of hyperbilirubinemia? When is the onset? Is it early or like how it is now on day 3, or it is going to be a late onset?
It has early onset. It presents on the day of birth.
Very good. And also you have mentioned here that they develop neonatal hyperbilirubinemia on 3rd day of life. Now you may want to actually give us more detail. When was it first noticed, or was it not noticed and they only noticed it on 3rd day?
Sir, parents noticed it on 3rd day of life, for which he was brought to the hospital for checkup. And
they did the exchange transfusion on the same day?
Yes, sir. They did.
So, how does birth weight affect management of hyperbilirubinemia? So we know, smaller the birth weight, more risk of getting into a neonatal bilirubin encephalopathy. Your preterm child, you're more like the brain-brain barrier, blood-brain barrier is going to be weaker, and there's a higher risk of getting into hyperbilirubinemia. Okay.
Yes, sir.
What is the importance of noting when the stools were passed with respect to hyperbilirubinemia? You've taken very nice history. That's why I'm just analyzing the importance of each statement. So tell us, why did you ask for passed first stool in 24 hours?
For some surgical cause delayed.
When does a newborn pass stool normally? Or let me ask other way around. When it is considered abnormal if he or she has not passed stools? Till what
More
time?
than 24 hours.
Very good. Excellent. Can you rename yourself other than iPhone? Otherwise, I'll have to call you iPhone.
Neha.
Neha, thank you. Well said. So urine, one baby may pass even up to 48 hours, but stool normally they pass up to 24 hours. And what are the causes why somebody can have a delayed passage of stool?
Heart-sprung disease can present.
Okay, very good. Delayed or non-passage can be because of imperforate anus, meconium
Yes, sir.
ileus, Hirschsprung's disease. Okay, a lot of such causes are there. And you have written G6PD was not deficient, right?
Sir.
Very nice. So tell me, is it possible that the child was G6PD deficient but was not diagnosed at that time? What is the paradox of missing a diagnosis of G6PD? Anybody? So when there is acute hemolysis, not in the neonatal situation, but in a bigger children, if there is G6PD deficiency and hemolysis because of G6PD deficiency, the older RBCs are more susceptible to hemolysing, and they would hemolyze. So the remaining RBCs, the young RBCs, have reasonable G6PD or moderate G6PD activity.
Yes,
and so when it is expressed as per gram hemoglobin, you may not get a G6PD deficiency if it's otherwise a G6, even in otherwise G6PD deficient patient. So you sometimes have to repeat a G6PD level after a few days or week in order to confirm your diagnosis. Can a female child have G6PD deficiency?
Yes, rarely.
When? Neha, tell me.
So means when I could not say, but I have seen a case. A girl was having G6PD deficiency.
Excellent. Somebody has written in the chat box, Dr. Atindra has written, if it's a Turner syndrome, correct? That is good. So that is one possibility. The other possibility is that if both parents are G6PD carriers, or mother is a carrier and father is affected, then their child can have, a female child can also have G6PD. Okay, that's one thing about G6PD. Okay, so you think this child required, how could you have prevented exchange transfusion? What you would do if you saw a child who is 2.75 kg, breastfed baby, both A positive, on day 3 of life with 20 bilirubin. We are not saying 23. It's come at 20 bilirubin. It's come to you predominantly indirect. How would you manage at that time? Would you straight away do exchange transfusion? Yeah, Garima has written extensive phototherapy.
Triple surface phototherapy.
Very good. So what do? You prepare for exchange transfusion, keep things steady, and start triple surface, double surface, whatever is best available for you. Make sure hydration and other things are taken care, and repeat after some time and see if you have got certain drop in bilirubin. Then you don't have to do. Otherwise, you will have to, and you can follow the bilirubin chart for the same. Okay. Can we go to the next slide for neonatal seizures? So do you think that this hyperbilirubinemia has anything to do with the current problem?
Yes, sir. It may have some cases of hereditary anemias can present with may require exchange transfusion during neonatal period.
Very good. Namely,
hereditary spherocytosis. Then
very nice. Okay, good. And how will you diagnose hereditary spherocytosis in the newborn age group? Anybody? Okay, Garima said flow cytometry. That is when you suspect, you will confirm your diagnosis, but or osmotic fragility. But otherwise, on CBC, peripheral smear.
We're getting spherocytes in peripheral smear.
How do you make out? How do you differentiate a spherocyte from a normal RBC? But morphology wise,
spherocytes are of comparable shape with RBC, but they have no central parallel.
Excellent. So Dr. Vatsala also said the same thing. You are also saying the same thing. They are slightly smaller in size and they lack the central pallor. And if you visualize, RBCs are like a disc with a center which is pressed.
Yes,
And
sir.
so there is more RBCs on the side, more hemoglobin or more reddish color on the side, and the center is relatively pale.
Pale.
But because spherocytes are round, they have redness all over and there is no central pallor.
Yes, sir.
Okay, and that's one of the reasons by which they break easily in intravascular, and then that's why they have hemolysis. Can anybody tell me one CBC parameter which will be abnormal?
MCHC.
Excellent. MCHC. And what level would you consider abnormal? How much?
More than 36 is highly
Brilliant.
likely to be.
You are so good. All of you are answering very well. Thank you. Makes me very happy. So tell me some other see, when you answer nicely, then you have to ask more questions and difficult ones, right? So let's discuss MCHC. So which other conditions you get elevated MCHC? So in your exam, when you're discussing YY, if you answer one, they go to the next one. That's not a bad sign. It's actually a very good and encouraging sign. So tell me some other conditions where MCHC is elevated. You already said one of them which is not present in your history, which is very common in Durg Bhilai, Chhattisgarh area. A hemolytic anemia.
In sickle cell.
Sickle cell. Okay. MCHC is more in sickle, but not as high as in hereditary spherocytosis. Okay. The other conditions in which MCHC is very high is in autoimmune hemolytic anemia. Okay. So
Yes,
because there is clumping and rouleau formation, you can have very high MCV and high MCHC also. Okay. So that's about that. So you have also given me family history of the father.
Yes, sir.
Okay. Can you describe it one more time?
Father has history of recurrent jaundice and
Very good.
splenomegaly with gallstones, for which he was operated and undergone cholecystectomy, and simultaneously splenectomy was done at around 20 years
What do
of
you,
age.
other than Dr. Salil, what do you think will be height of the father? 5 feet 8 inch, 5 feet, or closer to 5 feet, or closer to 5 feet 8 and above? What do you expect? Anybody? It's T20 time. No, we can have a little bit of gambling. It's okay. Closer to 5 feet. And why do you think so? So hereditary spherocytosis, other than mild recurrent jaundice and gallstones, which usually are asymptomatic, so they may not have history of cholecystectomy, is growth failure. So they are usually slightly shorter in height, and that's because of chronic anemia due to hemolysis. Any other history, any other operative history would you have asked if there was no cholecystectomy? Yeah, PGs are answering on chat box. I think they don't want to be vocal, but I still don't mind. So far as they're answering, I'm happy. Come on, tell me. Which other surgical procedure is more, the children or patients with hereditary spherocytosis are at risk of? Sometimes splenectomy, correct? If the spleen becomes very large, or if they are anemic, or if they get into hypersplenism, or if there is a trauma, etc., and you have a splenic rupture, then you have to be careful. So you don't, so you take certain precautions for that. Okay, fine. What about other sibling? Who else is at risk of, in their whole family, who else is at risk of getting or having hereditary spherocytosis? Is mother at risk? 7-year-old sister, and who else is there?
5-year-old sister.
And 5-year-old sister. Okay. Suppose there was a 5-year-old brother and 7-year-old sister. Who will be at higher risk of getting hereditary spherocytosis? Come on, come on.
Both.
Come on.
Autosomal dominant, both have equal.
Correct. So nota is available. No, when you go to vote, nota is available. None of the above you can say. That means you're right. Both of them are at the
At
same
equal-
risk.
equal
At
risk.
equal. So 50% risk. What is the risk of mother having hereditary spherocytosis?
If her parents would have been affected or carried,
Correct.
then 25%.
Very good. Basically same as what is there in their given population, but we can't judge that. Okay, fine. So we have taken care of hereditary spherocytosis and okay. Just a couple of points on your history before we discuss the presenting complaint.
Yes,
And,
sir.
what are your thoughts about weaning for this child? Diet, I think you have done. I think the child is on good diet, right?
Yes, sir.
Said only 2-gram deficit and 200 calories, which is all right. I mean, nobody can be very accurate about the details in any case. Tell us, what do you feel? What is the problem? Can somebody say what is the problem in weaning, if there is any problem?
6.
Yeah, Dr. Ruchika. Dr. Salil, anything on you? Otherwise, I'll answer it.
So dal pani
Eh.
complementary.
Very good. So you don't want to give dal pani, right?
Dal pani.
Correct. What do you want to give instead of that?
So whole dal can be given, means instead of pani, and
Correct.
can
Mashed dal or thick
mashed
dal,
dal
whatever you want.
with, yes.
Yeah, very good. Anything else you want to add with dal? What is the what is the advantage of giving khichdi over dal?
Sir, it can
It's
be enriched
supplementary,
with
right?
fats.
They
Yeah.
complement each other, rice and pulses.
How do they complement? That is
Uh,
what I'm saying.
I'm,
Rice and dal is good. Tastes better probably.
Some
Anybody?
amino acids are deficient in pulses and they are present in.
Very good. Salil, you can appear next time. Don't wait for 2 years.
Yes, sir.
Straight away appear. You are in good shape. Okay. So let's go to the immunization. Just a bit of correction there. See, you already written nicely about immunized as per age, correct? Now, when you write immunized as per age, no, it's a good idea to mention as per UIP or as per IFP or UIP plus if any other vaccination have been given. If you
Yes.
are thinking of hereditary spherocytosis, child is only 3 or 10 months, but on examination, suppose you have seen a large spleen and things like that, and you are expecting a hypersplenism, then it's a good idea to mention whether or not they have taken the vaccines at which are useful for pre-splenectomy or post-splenectomy. Okay. So
Yes, sir.
capsulated organisms is protected by giving
All
pneumococcal and meningococcal.
pneumococcal,
And
meningococcal.
H influenza, obviously now it comes under UIP. Even
Yes.
pneumococcal now comes under UIP. But you have to remember that 3 or 10-month-old child, whether 3 years back under UIP, whether they got pneumococcal or not. Okay. So sometimes when you're presenting a case, child may be 5 or 6-year-old. And 5 years back, UIP was not covering a pneumococcal vaccine. So you should just be careful about what you are presenting if it is relevant to your patient.
Yes, sir.
And about milestones. So I understand that this child has normal age appropriate milestones, but it is just a simple advice from my end. When you're presenting in the exam,
Yes,
it's a
sir.
good idea to quickly mention what the child, at least if what the child is doing currently, and say child has attained age appropriate milestones. Okay. We'll
Yes,
not
sir.
dwell into that just now.
Yes, sir.
So now let's go back to chief complaint and let's discuss that. I'm not paying too much attention on VDRL and its management because you already elaborated, and child has no congenital issues, and the child is 3-year-old with normal development. So
Growth and
more or less, I am not worried about that. Okay. So tell me, what do you understand by fever for 3 days? Can you go to the description of fever?
Yes, sir.
Okay. So let me create some space here. Yeah. So no, go back. Okay. So you said sudden in onset. So which fevers are sudden in onset?
Viral infection.
Anybody can answer. Okay. So I'm keeping it open. Okay. Viral fevers can be sudden in onset. Okay. Okay. Malaria can be sudden. So let's put it that way. Which are not sudden in onset? So you know what I'm trying to argue on this is that every fever starts at some point in time. It's like that saas bhi kabhi bahuti wala story. So it's like kabhi na kabhi to first day tha, kabhi na kabhi to onset sudden hoga. Now this is something which fever is a one-time event. So it's always going to be sudden. So more than sudden onset, I would be thinking more in terms of what it was on the first day. Was it high on the first day and then change the pattern and so on and so forth? You also written low grade. So what is high grade fever?
More than 104 degree Fahrenheit.
Excellent. Okay. So that's one. Figures vary in different books, but 104 would be considered high. And 101, I'm not sure it's considered low, but yeah, okay.
Low, moderate.
Won't argue. Yeah, that's fine. What do you mean by continuous in nature? He got only 4 spikes, right?
So 4 spikes in a day means occurring every 6 hourly. And without having diurnal variation, without having variation of more than 1 degree centigrade.
Excellent. Very good. Also, you have to remember that if they have been you've written already relieved by oral medication, correct?
Yes, sir.
So if you have to give oral medication every time, and as soon as the effect of the oral medication is expected,
disappears. Yes, sir.
The fever comes up again.
Yes.
In that case, you can safely call it a continuous fever, even though the fever is coming down. So you say that fever comes back as soon as the effect of the antipyretic is getting over. Correct?
Yes. Yes, sir.
So once you say that, this diurnal variation and continuous fever go hand in hand in a way, but when you're giving oral medication, you cannot comment on the diurnal variation unless you have a clear-cut pattern of saying that, okay, he only got high fever in the morning in spite of medication.
Yes, sir.
Okay. So what do you mean by interfebrile period? The child is active. Why do you want to know what is happening interfebrile?
Because in viral infection, child remain active, but in bacterial infections, child remains sick looking during the interfebrile period. So basically, I want to differentiate whether it is a bacterial or a viral.
Excellent, excellent. Dr. Bala sir has joined and he wants to be muted, and he wants somebody else. Please unmute him. How can you mute Dr. Bala? Welcome, Dr. Bala. Dr. Bala sir, hi. Ask to unmute.
Sir, you can unmute yourself, sir.
Yeah, done. Thank
Perfect.
you.
Good evening, sir. Welcome, sir.
Good evening, sir.
First apologies to Tushar. I was held in traffic jam in Bangalore.
Yeah. No apologies. I just feel good. I'm not the only one who gets stuck in traffic. So
please go ahead.
I'm happy about that.
I don't want to interrupt. Please go ahead.
So Salil and everyone else on the group are doing a good job. I'm running out of questions.
Okay.
So I need you to intervene now.
Right.
Can we just quickly go through the slides again in next 2 minutes for a recap for Dr. Bala?
Yes, sir. Should I read it out?
Yeah, please, quickly. Yeah. Just say the salient features. Don't say everything again.
Yes, sir. Abdul, 3 or 10-month-old male child came with complaint of fever for 3 days, vomiting for 2 days, and pallor for 1 day. Child was apparently all right 3 days back, having then he developed fever, sudden in onset, low grade, continuous in nature, getting around 4 spikes in a day, no diurnal variation, relieved by oral medication, interfebrile period, child was active. Then he had 2 to 3 episodes per day of non-bilious, non-projectile vomiting, which was occurring usually after intake of food containing food particles. However, on third day of illness, mother noticed paleness in the child, for which he was brought to our hospital for further management. There was no history of seizure.
That's okay. You can go ahead.
Yeah, you can skip this slide. Don't worry.
Skip the slide.
Past history, he had 1 episode of febrile seizure in December 2021. Antenatal history, there was no history of fever with rash or lymphadenopathy or drug.
Normal.
VDRL
Yes, sir.
positive mother.
Mother
Third
was-
trimester.
Mother was, yes, sir.
Child has no congenital, not noticed to have anything abnormal. Was given treatment for the same. Normal developing, immunized well. Diet is good. On mother's milk, exclusive breastfeed till 6 months. And subsequently weaning done. Mother breastfeeding continued till 1 year, 5 months. There is interesting natal and family history. So please elaborate.
Natal history, baby developed neonatal hyperbilirubinemia on third day of life, for which he was admitted to an ICU and received exchange transfusion. ABO incompatibility, RH incompatibility was ruled out. G6PD was not deficient. Direct Coombs test was negative. Reticulocyte count was 2%. Baby had neonatal seizures, for which he was given Levipil for around 6 months and then tapered stopped. Baby hearing was normal. Then coming to family history, father has history of recurrent jaundice, splenomegaly, and gallstones, and had undergone cholecystectomy and simultaneously splenectomy at the age of 20 years of. And there was no history of blood transfusion in the parents, no history of sickling or seizure disorder in the family.
So what we have done till now is we have discussed everything other than HOPI. So Dr. Bala, please, if you can ask questions on HOPI.
2 or 3 things which require clarification for me.
Sure.
Yes, sir.
See, apparently all right means what is the age? This child is now 3 years old, isn't it?
3 years,
3 or
10
10
months.
months old, yes.
3 years, 10 months old. Apparently all right means what makes you say the child is apparently all right? No, how sure are you that this child was apparently all right? What makes you confidently say a child is apparently all right?
Anybody can
As per
answer,
the-
okay, in the
as
chat
per
as
the-
well as on
In
this.
fact, I will say your statement saying that he was apparently all right instead of he was all right, that creates a doubt in your mind as well as in my mind whether everything was fine with this child until 3 years or not.
Yes, sir.
What is it that I'm looking for? If you say child was all right, which didn't come anywhere else in the history. You're given the statement. On what basis you gave a statement that this child was apparently all right?
So what Dr.
Somebody is putting in the chat box.
Yeah.
Quickly. Somebody says
Child was growing well, developmentally.
Yes, sir.
and-
Developmentally was well.
no subjective
subjective
complaint, growing well, no failure to thrive, and asymptomatic before. All this. Did you capture all this from the history? Hello?
Yeah.
Yes, sir.
Yeah.
Yes, sir.
Salil, please answer.
Yes, sir. Yes, sir. It was mentioned in the history.
I never found anything about the growth of the child.
Correct.
Yes, sir.
And are you expecting the child's growth to be normal? That's another angle, because we just discussed what is the expected height of the father, right?
Yes,
And
sir.
we said he's going to be close to 5 feet because he may not be growing well.
Yes,
Is
sir.
there a possibility that the same thing will apply to the child also? That is what doctors asking.
Yes, sir. It can apply to the child as well.
See, the reason why I am asking is, if it is a chronic problem, the baby's growth might have been retarded, which would have given you clues from the parents. When compared to other children, this fellow is neither good in weight nor good in height. That is number one.
Yes,
Number
sir.
two, in a child, particularly from your geographical location, anybody with family history of anemia, I would always ask about the head size. Why is it important? Head and some faces.
Hemolytic faces.
Hemolytic. Definitely, I would have ensured that I am not missing anything which is going on for quite some time. That is one. The second thing is paleness. How did the mother notice paleness?
Child was looking pale with as she noticed his palms. Then he was brought to us.
Did she notice paleness earlier or only after?
No, only on the third day of illness she noticed paleness.
Before that, there was no fever at all.
No, sir. She didn't notice.
What are the situations in which a child with fever will develop pallor? Acute pallor. What are the causes of acute pallor? Say chronic pallor, you will always say that it is anemia, whatever the type of anemia. Acute pallor. 2 days fever, third day child is becoming pale. What are the possibilities that you had in mind?
Yeah, we're getting some answers on the chat. That is good. But as Naresh said, you can answer by unmuting yourself as well.
Let's see what they put in the malaria. Excellent.
Yes, sir.
Very common in your area. Aplastic crisis in sickle cell anemia. Agreed. Again, very common in your. Somebody has put blood loss. Excellent. And
acute.
Has put autoimmune hemolytic anemia. Bleeding. Malaria again. Other than this. Child becoming.
A male child.
Other than whatever you said. Suppose this child has received cotrimoxazole on day 1 and on day 3 child becomes very pale. I'm giving a clue. Anybody? G6PD.
G6PD deficient.
This is a male, is this a boy or a girl?
Male child.
Boy.
That's why I said male. Yeah.
All the more. Even without a drug history, you can have G6PD induced by infections. Not necessary that every time you should get only a drug exposure. Spontaneously it can come. Any acute infection can precipitate. Other than that, somebody has put dengue. Dengue, I'm afraid day 3 dengue, pallor, rather unusual. Dengue usually it is the other way. They become more pink than usual because of increase in hematocrit on day 3. Suppose the same story is day 5, day 6, day 7. Yes, some bleeding causing pallor I can think of, right? Even if it is shock, in dengue shock syndrome, you don't get the pallor unless the shock is due to bleeding. They are usually pink and polycythemic with the shock. So the shock
virus is one more answer on the chat box.
Yes. Let's see. Yeah, somebody has put parvovirus. Excellent. Anything else? You should also think of any infection other than malaria. See, there are a few infections which are notorious for causing acute hemolysis, intravascular hemolysis, which includes our good old friend, the pneumococcus. Pneumococcus, and of course, very rare surgical friend. What is a surgical friend? Which can cause hemolysis. Yeah, mycoplasma is pulmonology friend. Agreed. Surgical friend. Orthopedic friend. Clostridium welchii. Welchii is notorious for causing acute hemolysis, like mycoplasma or pneumococcus. H-flu also can cause, any viral infection can cause. Okay. And somebody has put artificial. Excellent. Excellent. Artificial valves. If you have Y valves, even if the child has got a large mitral regurgitation or a prosthesis, you can have trauma occurring in the valves causing hemolysis. Very well known.
And HUS is
And of
also
course,
mentioned.
HUS should not be,
HUSTT.
particularly if there is diarrhea. Okay.
And
Please go to
also,
the
yeah, also think about acute on chronic situations. If you have a borderline anemia and there is fever, then like any other stress, one could have acute on chronic anemia.
Now, from this history, do you think this is an acute problem or an acute on chronic problem? As nicely put by Dr. Tushar Mayer. Do you think this is an acute problem or an acute on chronic problem? Yes, please.
Salil, what do you think?
Acute on chronic problem.
Why? What makes you say this is acute on chronic?
Child had undergone exchange transfusion in the neonatal period.
Excellent. Child has undergone exchange transfusion, number one. Number two, child has, there is some significant family history also.
Yes, sir.
Significant family. This suggests that it could be an acute on
Chronic
problem. Chronic problem. Okay.
Also that he got jaundice without any blood group incompatibility. Though we said it could be minor blood group, but it could also be because of the family history that you have. So that also could be one more pointer towards hereditary phagocytosis, right?
Okay. Do you think this could be something very dangerous like leukemia or lymphoma or HLH?
Yes, sir. It could be from differential diagnosis could be there.
Absolutely, absolutely. It's not ruled out. It's not ruled out. In fact, your exchange transfusion, family history of cirrhosis might be totally unrelated. And that the child who's becoming so ill and pale in 3 days, one of the diagnoses you have to consider is a lymphoreticular malignancy. Lymphoreticular malignancy. Say somebody had put parvovirus. Parvovirus doesn't cause so much of an acute problem within 3 days. It's rather slow than something which is acute and catastrophic like malaria.
Why does it not cause? Anybody can think about why does parvovirus infection not cause acute anemia, quick acute anemia? What is, whenever there is anemia, what are you thinking? How do you approach that suspect? Either there is a blood loss, correct, out of the body or inside the body. If it is whether RBCs are breaking in the body or RBCs are not being formed in the body.
Yes, sir.
If RBCs are not being formed, at least the present RBCs will take some time to die by the time the new ones are formed.
Yes, sir.
Get my point? So that's why, though it can be severe, it's unlikely to be acute or sudden, right?
Yes, sir.
Please go to your negative history. Let me see your negative history. Why did you ask seizures and altered sensorium?
Because fever with vomiting, we can have.
But there is history of
NSM1.
febrile seizure, no, my friend. You can't say no history of seizures at all.
Okay, why did you ask
Yes, sir.
pain abdomen? Pain abdomen.
Can be a surgical.
Surgical?
Acute abdomen.
Acute abdomen. What acute abdomen will produce fever and pallor?
Fever.
Give some examples. See, you must be able to defend yourself. What diagnosis did you think of when you said there is no history of pain in the abdomen?
Intussusception can.
Intussusception, does it produce pallor like this?
No, sir. Pallor will not be there.
Yeah, so I don't think it. You must be careful. If at all one has to think of an abdominal pain as an important symptom in this child, only cholelithiasis due to hereditary spherocytosis. Other
Yes,
than that,
sir.
I don't think you'll be able to justify abdominal pain, right?
Yes, sir.
Okay. No history of loss of appetite or jaundice. Okay, fine. What loss of appetite? What's the significance?
Maybe a chronic infectious disease.
See, but the duration of illness is only 3 days, you know.
Yes, sir.
3 days. Do you think this child would have been eating well in the last 3 days after onset of fever? Very unlikely.
Yes, sir.
Jaundice, agreed. Clay-colored stools are, when there is no jaundice, where is the question of clay-colored stools or dark urine?
Yes, sir.
I think it's irrelevant. Burning maturation, why did you ask?
Child presents with fever can have a UTI.
The UTI, will it cause, which UTI will cause pallor, intravascular hemolysis? See, this is the problem. See, you shouldn't be saying things which are totally unconnected. Do you expect UTI in this child? Very, very unlikely. And the other important point you must remember, there is a difference in the symptoms of UTI below 3 years and above 3 years. Above 3 years, urinary symptoms are always present in UTI. Only below 3 years, fever may be the only manifestation, other manifestations may not be there. 3 years and above, you'll always get some dysuria, loin pain, etc. Bleeding, okay, agreed. Blood loss, blood transfusion, agreed. Fatigue and pica, why?
Nutritional cause of anemia.
Nutritional cause.
More for duration
Iron.
or onset of anemia, right? That would
Fatigue
be
is
more.
for chronicity, as rightly said by Tushar. Pica is not very specific for anti-inflammatory anemia. In fact, pica is more a behavioral problem than a nutritional problem.
Yes,
Okay,
sir.
but still, I agreed. Your point is well taken. Rash, why did you ask?
Fever with a rash.
No, in this child, why did you ask? Somebody has put in the chat box HUS, purpura.
HUS, purpura.
Purpura, vasculitis due to mycoplasma.
Can you be talking about henoxal in purpura? Do you want to defend on those lines? No, think before you answer. I asked doesn't mean it is a yes. What is the chronology of fever, vomiting, rash in a child with henoxal in purpura? What comes first? What comes next? What comes later? So it's usually fever, rash, then abdominal complaints, and then urinary complaints. Okay.
And fever as a prominent manifestation is rather unusual in henoxal in purpura.
Absolutely.
Agreed. Rash, you should always think of a few things like, hemolytic uremic syndrome, leukemia, viral infection, mycoplasma,
Yes, sir.
right? Even, rarely meningococcal when you have pallor due to shock.
Yes, sir.
Right, go ahead. Tushar, you can take over from here. You can complete the discussion on the history. And
So
then,
just go back to let's go ahead and go to the summary of this patient, and
Yes, sir.
then we go to the differential diagnosis. We are still to look at the examination.
Yes, sir. Summary: a 3-year, 10-month-old male child came with complaint of fever, vomiting, and pallor, with postnatal history of exchange transfusion on day 3rd of life, with positive family history of recurrent jaundice, gallstones, and splenectomy in father. I would like to consider the possibility of hemolytic.
So it's good to talk about thinking of hemolytic anemia, but you may want to qualify further by saying congenital, acquired,
Yes, sir.
what type of
Congenital.
hemolytic anemia. Also, whenever a patient presents to you, the presenting complaint has to be given importance. Okay.
Yes,
So
sir.
currently, what is the cause of fever and vomiting also you must address.
Suprahead viral
For that.
infection.
Yeah. Okay. What type of hemolytic anemia are you thinking?
Membranopathy, RBC.
Okay.
Yes, sir. Because
Before that, please tell me whether this hemolysis is intravascular or extravascular.
this is
I'll ask you intracorpuscular or extracorpuscular.
intracorpuscular.
See, when the hemolysis, yeah, that is lysis of the RBCs,
Yes, sir.
can occur due to factors outside the cell
Yes, sir.
or in the cell. When you talk about cell, you talk about the membrane, then you talk about the
Hemoglobin.
inside the cell. That is a hemoglobin. And then you talk about enzymes. So anywhere there can be defect.
Yes, sir.
With this history, if you say there is a possibility of hemolytic anemia, where do you think is the defect with this history?
Defect in the membranes of RBCs.
What makes you say it must be a defect in the membrane?
Because the membranopathies are ruled out with the history. Their parents are not giving any history of transfusion, and sickling was not positive. And enzymopathy is also ruled out. G6PD was not deficient during the natal period when it was diagnosed. So narrowing to the membranopathy, I would like to consider.
So you think this is a membranopathy? Now, if it is membranopathy, particularly with the family, say jaundice and splenectomy in the father, tell me.
Cholecystectomy in the father. Sorry,
Yes, sir.
not
Cholecystectomy and splenectomy.
Cholecystectomy
Both.
and splenectomy are both.
Yes, sir.
Oh,
Fine,
Yes, sir.
fine. With that history, tell me what important point in history would have given a clue that this is also the same problem. Something to do with the abdomen. You could have asked some question to the mother. She would have definitely given you some clue.
Abdomen distension.
Distension, more specifically, abdomen distension.
Upper abdomen distension.
Upper where specifically?
Spleno.
Right, left, center. Right, left, center, all over.
Left of the center, left side.
An intelligent mother would have told you if it is spherocytosis,
Splenomegaly.
the abdomen is getting distended in the left upper quadrant gradually over the last 1 or 2 years.
Yes, sir.
Okay?
Suppose you did not know that this was G6PD deficiency and father did not have this history, still,
Yes,
would you consider G6PD as one of the option, or you would still not consider this? People on chat can also vote. I'll repeat my statement. With no history known about G6PD status and father not having history of hereditary spherocytosis, would you consider G6PD or not?
Yes, sir. We will consider it as a differential diagnosis. Being a male child, G6PD is more.
So I will ask you another question. What is the hallmark of acute hemolysis of G6PD deficiency?
Hematuria.
Not hematuria. What is it called? Hemoglobinuria.
Hemoglobin. Yes, sir.
Right. So you have dark colored urine as a possibility. So if that would have pointed more towards G6PD deficiency and not otherwise. Okay. Can it still be sickle? Because he is from a belt where you see so many patients with sickle. Just because the father has hereditary spherocytosis, I agree that you want to keep this up there, but as Dr. Bala said, there is no history of lump noticed by the mother while giving bath or while playing with the baby or something like that. Sickle, you get splenomegaly, but that's the second discussion.
There would be a history of crisis if he had sickle, but it would be a sickle cell trait.
Oh, but sickle cell traits don't develop pallor on
Yes.
fever, right? So what you are saying is correct. There is no history of pain associated or any crisis associated, symptoms of crisis associated with this acute onset pallor. If we are to believe that this is acute onset pallor. Okay, so that's why
Yes, sir.
that's a pointer against sickle from history. Anything else, Dr. Bala, or we can go for the
No,
examination?
see, two things in an area like Bhilai, I don't think sickle can be completely ruled out. More than sickle thalassemia trait together can play havoc like this, and the infection might just be a what do you call
Precipitating factor.
event which brings to the notice of the parents the severe problem. Here, definitely, there will be some history of growth retardation. That's why I initially asked questions on that. If there had been some growth retardation and some abdominal distension, then the possibility of a sickle or a sickle thal trait together cannot be ruled out. Having said that, father has had, splenectomy, cholecystectomy, and spherocytosis being a dominant, autosomal dominant disorder with history of exchange transfusion. My first diagnosis is, of course, will be a membranopathy, a hereditary spherocytosis. That's what would be my thinking. Though being a male child, some febrile illness, acute pallor, G6PD deficiency is not entirely
No.
ruled out. That too, in your state, malaria is again so common, and the administration of chloroquine is so common. Chloroquine is well known to precipitate G6PD induced hemolysis. But again, the absence of black urine from your history, although you didn't mention, you mentioned only dysuria, didn't mention any urinary. Of course, you mentioned no high colored urine. You didn't
Yes, sir.
mention about black urine specifically. The possibility of G6PD is not very, very high, very, very high. And autoimmune hemolytic anemia, rather young age, 3 years and 10 months, and nothing seems to be happening outside the hematological system in this child. And it's a male child, no abdominal distension suggesting chronic splenomegaly, not a likely diagnosis.
So sickle thal will present as sickle or present as thal, or sometimes sickle, sometimes thal.
A combination of both. They can present.
No. I'm asking Dr. Salil. Sorry. No.
Sorry,
I'm
sir.
asking him. Does a sickle thal patient, meaning double heterozygote sickle thal, clinically manifest as a thalassemia or as a sickle cell disease?
They can present as both sickle or thalassemia. They
More
may
commonly?
present
Usually like a sickle
sickling.
rather than a thal. Okay.
Yes, sir.
But one thing I'm wondering why nobody is questioning us is you have no history of jaundice.
Yes, sir.
So tell me, out of these hemolytic anemia that we have discussed, which one does not have jaundice? Sickle should have jaundice. Hereditary spherocytosis
Yes,
should have jaundice. G6PD with a bleed should have jaundice. Only thalassemia may not have
Thalassemia.
jaundice.
Right.
So this should be thalassemia.
Yes, sir.
No, not yes, sir. So what is the situation why there is no high colored urine also and there is no jaundice also? Would you expect high color urine in these jaundice associated with these jaundice?
No, sir.
No.
If it is associated with G6PD, then only we can.
Correct. So we are talking about not jaundice in the urine. We are talking, bilirubin in the urine, bile salt, bile pigment in the urine. I'm sorry, but we are talking about a hemoglobin in the urine. Correct. Because it's an indirect bilirubinemia, that's why you don't get high colored urine in these jaundice. That's what I'm trying to say. Okay, can we go to the examination?
Yeah,
Any
yeah.
other questions?
Please go ahead.
Yes, sir. Coming to the examination part, child is conscious and sitting comfortably in bed. He is playful and active. Child is afebrile. Pulse rate was 120 per minute, regular in rhythm, normal in volume, no special character, no radial or radiofemoral delay. Respiratory rate was around 24 per minute. SpO2 is 98% on room air. BP is around 100 by 60 mmHg in right upper arm in sitting position. Examination was done after blood transfusion was given, so I was not getting any pallor or icterus in the child. Had
But you
coming
didn't
to
mention about blood transfusion in your history. Have you mentioned? Did I miss it?
yes, I haven't mentioned, sir. On
He
after
mentioned
getting
no history of transfusion. That's what he said.
yes, sir. After admission, the
No,
baby
in your
child
presentation,
received.
you said no history of transfusion.
No. So Dr. Salil, I'll tell you what. So
Yes.
either you present at whatever has happened on admission, then your examination also should be at admission.
Yes, sir.
And if you are going to present your examination, say 2 days after admission, then you
Yes.
say whatever was there till admission, and you mention that after admission, patient was admitted 2 days back, and a blood transfusion has been given in last 2 days.
Yes.
Okay.
Yes, sir.
Go ahead.
Coming to head to toe examination, head appears to be dolichocephalic, faces appears to be normal, nails appear to be normal, no cyanosis or clubbing seen, no significant lymphadenopathy felt, ears appears to be normal, no neurocutaneous marker visible, no skeletal deformities observed, external genitalia appears to be normal. Anthropometry, weight, observed weight is 13.9 kg, expected is around 15 kg, weight is between 3rd and 50th centile for age as per WHO growth chart. Height, observed height is around 103 centimeter, expected is around 95 centimeter. It is between 50th and 90th centile for age as per WHO growth chart. Head circumference around 48 centimeter, expected is around 49 centimeter. It is between 3rd and 50th centile.
No, why are you so unpatriotic in taking WHO centile and not IAP centile?
Because child is less than 5 years of age.
So what? Indians IAP standards are there, no?
Yes, sir.
IAP growth charts are there, no?
IAP charts are used for more than 5 years of age.
Who said you should not use it for less than 5 years? Tushar, is that the norm?
So basically the growth charts below 5 years, to my knowledge, are same as IAP and WHO. They are same.
No, but you should mention only IAP
Correct.
and not WHO.
That's correct.
Yes, sir.
They are different after 5 years. IAP charts are different than the WHO.
Of course, statistically, the significance in difference is not much. So we are supposed to use only IAP charts. The examination also, whether it is below 5 years or above 5 years, you always mention as IAP growth charts rather than W. Of course, there are more examiners who may be more patriotic than me and they may put -5 marks. You mentioned WHO, unlike me. But I'm just warning you, please use
Yes, sir.
only IAP growth.
IAP growth.
IAP,
Yes.
right? And
Yes,
I
sir.
don't know what 3rd and 50th centile.
Yes, sir.
That is the problem of WHO growth chart.
That's a
They have
problem.
third,
That is a
they have
problem.
third, yeah.
That is a
they have
problem.
the
That
third.
is a problem. So
They
you
have
are,
the third centile line.
you're getting such a wide range, right?
Yes, sir.
That is a problem with WHO chart.
WHO.
Okay, what's your inference?
Looking at the anthropometry, child is, I think, having normal growth because it is above third centile.
You measure the mid-arm circumference.
Sir, I have not taken it up.
Is it important or not?
Yes, sir.
Anybody on the chat, tell us why is mid-arm circumference important? More important. What is the importance of Sam to rule out? No.
Sample or not sample? What, see, first
Age independent criteria, very good. So that is the important one. Okay.
see, two things. One is that I would definitely expect, in fact, if you have a picture of the baby, I can tell you what the mid-arm circumference is likely to be. Of course, 33 years, the weight is fairly good, but mid-arm circumference is certainly important. What are the advantages of mid-arm circumference? There are two things. One is that
Age in
within 6 months and 1 to 5 years, it's 1 to 5 years is an age-independent criteria. Easy. There is very little error that can take place in measuring mid-arm circumference. A health worker can diagnose malnutrition based on it. Another thing is, it's very easy. 13.5, above 13.5 is normal.
normal.
12.5 to 13.5 is what?
Mild.
No, moderate PEM.
Moderate.
That's what you should know. There's no mild PEM in with reference to mid-arm
Mid-arm.
circumference. Okay.
Yes,
When it
sir.
is 12.5 to 13.5, it is moderate. Less than 12.5, it is
Severe.
severe.
The same goes for malnutrition. -2 to -3 SD, weight for height, is moderate malnutrition. Less than -3 is severe malnutrition. There is nothing like mild malnutrition. Anything above -2 SD is considered normal because it comes in the Gaussian curve, 5 percentile, 5 to 95 percentile, or sorry, 3 to 97 percentile.
Yes, sir.
Go
Yeah.
ahead.
Also, it's a good idea to check weight for height measurements also. Okay.
Yes, sir. Yes.
You are okay because your weight and height both are not in, neither of them are in negative.
Yes,
But
sir.
it's still good to compare, because if your height is, say, close to 97 centile and weight is close to 3rd centile, then you would still be looking at what is the reason that the child has not put on weight in spite of having grown in height. Okay.
Yes, sir. Yes. Coming to systemic examination, per abdomen examination, inspection, abdomen upper quadrants appear to be distended, scar, superficial veins or periumbilical engorgement not seen. Umbilicus is in midline, appears to be normal. Flanks are free, hernial sites are free. No visible peristalsis and genitals appear to be free, to be normal. Coming to palpation, abdomen is soft, no guarding, rigidity or rebound tenderness present. Liver is palpable 3 cm below right costal margin and mid-clavicular line. Liver span is around 8 cm. Surface is smooth, lower border rounded, regular, soft in consistency, non-tender, non-pulsatile. Spleen is also palpable 3 cm below left costal margin and mid-clavicular line, firm in consistency and non-tender. On percussion, no shifting dullness present. On auscultation, bowel sounds heard. Then CVS examination, S1, S2
Wait,
heard.
wait,
Normal, normal,
one minute.
normal.
Please go back to the previous slide.
Yes, sir.
What about the liver span?
Liver span is around 8 cm.
8 centimeter. Normal or abnormal for 3 years?
Abnormal for 3 years, it is around 6 to 7 cm.
8 centimeter is just borderline.
Yes, sir.
Between 3 centimeter. Okay. Right. Which is more, liver or spleen?
So both were palpable 3 cm below the right costal margins.
Okay. Okay. Go ahead.
Coming to CVS examination,
Please
S1,
putting in the chat box spleen, I would agree, because see, liver normally itself 1 centimeter, 1 to 2 centimeter can be normal. So 3 centimeter liver and 3 centimeter spleen. I would say splenohepatomegaly rather than hepatosplenomegaly. Very subjective, but
yes,
I would tend to think that spleen is probably more significantly enlarged than
liver.
that too with the liver span of only 8 centimeter. Okay.
Yes. Coming to CVS examination, S1, S2 heard normally.
It's okay. It's normal, normal, normal. Go ahead.
Yes,
We'll save time.
Summary: 3-year, 10-month-old male child presented with chief complaint of fever, vomiting, pallor with normal growth with significant hepatosplenomegaly with postnatal history of exchange transfusion on day 3rd of life with positive family history of recurrent jaundice, gallstones, and splenectomy in father. A probable diagnosis of congenital hemolytic anemia is considered with possibility of hereditary spherocytosis.
So my only contention here is that you have not noticed jaundice in this patient on your examination also. Hereditary spherocytosis can have very mild jaundice and parents can miss it. I totally get it. But
sir.
if you don't see jaundice and there is pallor, both together, then I would be very careful before saying. And in your history, preferably write spleno-hepato, as Dr. Bala mentioned, rather
Yes.
than hepatospleno, because that also has a different connotation.
Yes, sir.
A child who has undergone exchange transfusion, whose father has had hereditary spherocytosis, who's got more of splenohepatomegaly, I'll be surprised if there is no jaundice if it is spherocytosis. Okay.
Yes, sir.
See, even sickle cell anemia, sometimes you may not make out much of jaundice, but spherocytosis, jaundice is something which is often consistently made out. Right?
Yes.
In fact, it is, in fact, in the exam, suppose this case is kept, you should
Yes, sir.
actually examine the father and the mother for jaundice as well as splenomegaly.
Yes, sir.
Okay. You should, in fact, you should at least make an attempt.
Yes, sir.
Right? You should ask them to show their conjunctiva, sclera, and then palpate the abdomen and verify the history.
And make sure you don't report splenomegaly in father.
Yes, sir. He had undergone splenectomy.
Correct.
Yes, sir.
Hmm?
Can you show us the investigations?
Are there any pictures of the boy?
Yes, sir.
Please show me.
Here is the picture.
Actually,
Having,
he seems to be nutritionally okay. In fact, here the left upper abdomen seems to be more distended than the right. Tushar, don't you agree?
Yeah.
Left, of course, it is.
So it's a good idea to take pictures also from the point that you are expected to examine, right? That is the reason why you examine the shape of the abdomen and the bulge from the toe end of the patient.
yes,
This
sir.
looks like more of a splenomegaly than hepatomegaly, though it is taken on the side. Any other pictures? Any other pictures of the boy?
No, sir. These 4.
1 minute.
No,
One
so
more
here,
point.
this is the liver marking.
Yes, sir.
This is
Picture
not 3
1 is
centimeters.
this is showing a liver span.
Please fight.
It is around 8.
This is not, I mean,
Umbilicus is not normal. It is actually pushed down, and maybe stretched to the, I don't know, I'm not able to see since it is from the side, some shadows. It is pushed down. Any other pictures?
No, sir. These 4 only.
Okay.
But even the spleen which you have marked on that side
Yes, sir.
doesn't look. Are you sure it's 3 centimeters? I'm really surprised. It looks much bigger. Anyway, I will take your word for it. No worries.
Yes, sir.
Show us the examination. Okay.
Investigations.
Investigation. Sorry.
Hemoglobin was 5.6 gram. This was before blood transfusion. TLC was around 10,400. Platelet were normal. PCV was 16.6. MCV was 18.1%. MCH was 27.4 picogram. MCHC was 33.8. RDW was 23.8. ESR was slightly elevated, 56 mm. Total serum bilirubin was 2 milligram per deciliter. Direct was 1.4. Indirect was 0.6.
Is this normal or abnormal?
Total serum was 2, so it is not. It should be less than 1. It is abnormal.
Which is more, direct is more or indirect is more?
Thyroid.
What do you explain? What SGPT? What about SGOT?
SGPT is normal.
OT.
SGOT was not performed.
Okay. Where do you get discordance in SGOT and SGPT?
Chat box answers.
Where do you get gross discordance between SGOT and PT? Anybody? Commonest?
Treatable hepatic condition.
Drug?
So you have two examiners. Now, if one asks a difficult question, the other will always give you a clue and support you.
Any drug-induced liver injury, SGOT will be more elevated than PT.
Yes.
Right? Any drug-induced. Similarly, even non-hepatotropic viral infection, OT may be more elevated than PT.
Wilson's also is one other condition where you have OT higher than PT.
Yeah.
Okay.
Okay, right.
Yes,
Good.
Then malaria was negative, Coombs test was negative, blood group was A positive, LDH was 393 international unit per liter. Coming to peripheral smear findings, RBC morphology, anisopoikilocytes were seen, micro and macrocytes were seen, elliptocytes, teardrop cells and spherocytes were present. WBC morphology was normal, platelet was adequate. Remarks suggestive of hemolytic anemia. Coming to USG abdomen.
No, electrophoresis.
HPLC.
One
Yeah.
minute. Before that, please go to the
Electrophoresis.
previous slide. And on a previous slide, peripheral smear.
Yes, sir.
What are the clues to the presence of hemolytic anemia in the peripheral smear?
Micro and microcytes.
No. Hemolytic anemia. You have a child with hemolytic anemia. Forget the type. But what are the general clues where a pathologist, by looking at the very smear, will start suspecting hemolytic anemia? Somebody has put teardrop. They are not very specific. No.
Bite cells.
No. Okay. When there is hemolytic anemia, which type of cells will be prominently seen in the peripheral smear, which is not seen in a normal peripheral smear?
What is elevated?
Reticulocytes.
Equivalent to reticulocyte. Reticulocyte is, how do you identify reticulocyte? What stain do you use? What stain?
Yeah, supravital, correct.
Supravital stains.
Supravital staining. Okay. Whereas in the normal smear, you can't appreciate reticulocyte count. Something else will be there which will give you a clue that there is increased production occurring because of over-destruction. Immature RBCs, giving clue after clue. Normoblastia, whatever the type of hemolytic anemia, whether it is thalassemia, sickle cell anemia, autoimmune hemolytic anemia, spherocytosis, increased presence of normoblasts in the peripheral smear is equivalent to an elevated reticulocyte count. Reticulocytes cannot be made out with the ordinary peripheral smear. Normoblasts are RBCs which look like WBCs. That is normoblasts. That indicate that the bone marrow turnover is increasing because of hemolysis. The rest of the things, teardrops, spherocytes, elliptocytes, yes, they are all specific diagnostic features of an individual hemolytic anemia. Okay.
Yes, sir.
Right? For example, you get acanthocytes in, for which condition you get acanthocytes? Burr cells are acanthocytes. What is it specific for? Microangiopathic hemolytic anemia. That should be your answer. Any microangiopathic hemolytic anemia will produce acanthocytes or burst cells. Very specific. Very specific. Acanthocytes are very specific. Okay.
Yes.
Nucleated RBCs are nothing but normoblasts. Increase amount. Right?
Yes, sir.
Go ahead.
Coming to USG abdomen, liver is enlarged in size around 14 centimeter. Then spleen is also enlarged in size around 13.5 centimeter. Rest were findings were normal. An impression of mild hepatosplenomegaly was given.
What other investigations do you have asked for specific diagnosis?
Osmotic fragility test for
How is
hereditary.
osmotic fragility test performed? How do you interpret osmotic fragility test?
We check the fragility of RBCs. Since the spherocytes are more prone to hypotonic saline. In normal, it is usually performed by placing the RBCs in hypotonic saline, that is starting from 0.9% to 0.1%. Normally, hemolysis starts from 0.5% and it is complete hemolysis we get around 0.2 to 0.3%. But in hereditary spherocytes, it starts usually around 0.7% and complete hemolysis we get around 0.4 to 0.5% hypotonic saline.
You should do this test at what temperature?
At 37 degrees.
37. Anything else?
What other tests would you have performed in addition to that?
Of eosin 5 melimide test. It is a dye which binds to band 3 and we check for the fluorescence.
No, more importantly, won't you ask for hemoglobin electrophoresis?
HPLC and sickle, yes, sir.
You should ask for it, particularly in your geographic location. Even if it is spherocytosis, they may still be carriers of sickle or thalassemia.
Yes.
Your state is notorious for all this, right?
Yes, sir.
And that is one thing you should have done. Then, of course, Coombs test, you already mentioned it has been done.
Yes, sir.
Right?
Yes, sir.
Okay, right. Now, what do you do for this child?
Since hemoglobin is less than 7, then
did you do osmotic fragility? Was it abnormal?
Sir, we have transfused the child, so fragility test would be performed after.
Always in such situation, it's always better to arrange a transfusion just before transfusion. Take all the samples required.
Yes, sir.
Okay. Now, what do you do for this child on long term? Suppose the parents can afford and you want to confirm the diagnosis spherocytosis. Yeah, what do you do to confirm diagnosis? Anybody?
Yes,
no. Can you genetically confirm the diagnosis? Yes. How? How? Somebody has put yes. How? Genomic sequence, genetic studies. Take a sample.
Yes,
right? Exome sequencing will definitely give a confirmatory diagnosis. Nowadays, that is the best. And in fact, you can prove it in the father also. Okay, father as
yes,
well
sir.
as they can afford, you can do a whole exome sequencing to confirm the diagnosis.
Yeah, whenever they ask you, suppose management in this case, no, don't stop short here. Suppose you're diagnosing hereditary, make sure that I will examine and investigate the other two siblings. Just because they have been asymptomatic till 5 and 7 years does not necessarily mean that they don't have hereditary spherocytosis.
Yes.
Next part is what do you counsel the family? How do you counsel the family? How will you counsel the family?
To get a regular follow-up, abdominal USG. Abdominal USG is done to check for gallstones.
Why abdominal USG? How frequently do you do abdominal?
To look for gallstones every 2 to 3
Every
hours.
month, every week,
Every 2 to 3 years.
every year. Annually, they are supposed to undergo ultrasound scanning for gallstone. Number one. What else will you? What drug will you give to this child?
Iron supplementation, folic
Iron
acid.
supplementation. No, no, no. Again, you will end up only getting iron overload, like thalassemia. So, what supplementation is required for these children?
Folic acid, vitamin B2.
Why do you give folic acid? B12 is not required. Folic acid, why?
They're prone to
anemia because of increased turnover.
bone turnover. Bone marrow turnover.
You should give folic acid.
Yes, sir.
Third is to educate the parents about worsening jaundice, fever, chills, indicating what? Fever, chills, and abdominal pain in this child. What will it indicate?
Crisis.
Biliary colic.
Yes.
Counsel the parents about the symptoms and signs.
Where will the pain be? Acute cholecystitis?
Left.
No, no, not left. Where? Liver is on the right side.
Right hypochondria.
And
shoulder, man, not epigastric. Shoulder.
Right shoulder. Right shoulder.
Right shoulder.
Shoulder. Okay, fever, chills, pain in the right shoulder, right hypochondrium, nothing but acute cholecystitis. Okay.
Yes, sir.
Treat aggressively with antibiotics and then consider cholecystectomy. And you have to counsel the parent that cholecystectomy might be required at a particular age. And what else you counsel? You should counsel the parents about the mode of inheritance of the disease.
Yes,
and
sir.
the risk of recurrence. What happens? Suppose the mother becomes pregnant again.
Yes, sir.
Yeah.
Then 50% chances.
50% chance of irrespective of the sex of the child.
Yes, sir.
50% chance because autosomal
Dominant
mode of inheritance causes 50% risk. Okay. You'll have to counsel them that splenectomy can be considered only above the age of
5 to 9 years.
Yes, 5 years. The longer you postpone, the better because of the risk of infection following
encapsulated organism.
Very importantly, these children should be vaccinated even before splenectomy against
pneumococcal,
typhoid,
and Haemophilus influenza.
Meningococcus.
That is very, very important. Very, very important. Okay.
Yes.
Right. Yes, Tushar.
No, that's good. I think he's done remarkably well, Dr. Bala, because he's a first-year resident. And he's not only presented well, but he's answered also very well. He's done his reading, and I'm very, very happy, Dr. Salil. And thank you, everybody else, including Durg Bhilai and Naresh ji. Thank you so much.
Are there any other comments, any questions that need to be clarified?
Any questions you can put on the chat box, okay?
Dr. Motwani, is there anything else?
I think that's all for today, sir. I don't think there are any more questions in chat
Any
box.
questions or any comments from your Bhilai faculty? Anybody who wants to say something or you want to clarify?
If there are any comments from the participants or other pediatricians, please you can unmute the mic and please go ahead. Okay, sir. Then.
I sincerely apologize for joining late.
No issue, sir. In fact, thank you so much, sir. In spite of being so busy or in Bangalore with your work and all, still you could find out time and you could join here, sir. We are very happy and we are pleased, sir. Thank you so much for that. And of course, Tushar Maniar, sir. Thank you
Thank
so
you
much.
so much. Thank you for inviting.
Both the learned experts. Today it was a wonderful case discussion. And congratulations, Dr. Salil, also for nicely presenting the case. And we would like to disturb Tushar Maniar, sir, more often from here on, if time permits for him.
Sure.
So
It's a
that will be a
pleasure.
request. That will be a request. And thank you again, our expert, Tushar Maniar, sir, Bala, sir, and all the participants who came in large numbers to make this webinar successful. And today it was very interactive session. So it was really pleasing that all the postgraduates, they participated. Thank again all the senior pediatricians from Chhattisgarh, Durg Bhilai, and across the state for turning out in good numbers. Thank you again. Thank you, sir. Bala, sir, Tushar, sir, thank you. And good night, everyone.
Thank you, Dr. Tushar.
Thank you, Dr. Bala.
Personally obliged to you for joining.
Not at all. It's always a pleasure. Bye-bye.
Thank you.
Good
Good night,
night.
sir.